And let's talk a little bit about the compensation shifts that occur. It's a little hard to see here, but we can blow this up a little bit. We have some diagrams here that show our PCO2 and our bicarbonate as items that are being weighed so that we can see the problem shift that occurs and then what happens during the compensation. So if I say that these are the problems here, we want to think of the compensations that would occur. And with acidosis, a low pH, metabolic acidosis means that the base is too low. We've decreased the level of base here. That's being shown in this diagram by the base being reduced and weighing less, if you will, on the scale. And then the compensation here would be to remove CO2. We increase the removal of CO2, bringing CO2 levels down, so the partial pressure of CO2, to help match that decreasing base. So this tells us that the partial pressure of CO2 has been reduced because the bicarbonate as a problem has been reduced. And so the compensation, right, as it's occurring should match the direction of the initial problem. Here for respiratory, the problem with acidosis is too much acid, a high level of CO2, high partial pressure of CO2, and the body is going to attempt to compensate by increasing bicarb levels, bicarbonate concentration, right, which is what we see here, bicarbonate. And like I said, it's hard to see, but the bicarbonate has increased, not decreased. And alkalosis, same thing, problem compensation. If bicarbonate levels are high, we want to raise the CO2 levels as well. Partial pressure of CO2 will increase to help balance out the high bicarbonate. And then the opposite, if the alkalosis is because the CO2 levels are too low, respiratory alkalosis, our compensation that we would see here is to decrease levels of bicarbonate within the body fluids. So before we look at some of those compensation mechanisms here, let's first just run through some of the common signs and symptoms associated with acidosis, alkalosis, and this goes for both respiratory and metabolic conditions. For acidosis, the primary effect that we're going to see is central nervous system depression. So low levels of acidosis, we'd see generalized weakness. More severe acidosis, individual is going to experience disorientation. They might experience coma, and most severe, when we're at the vital limit there, the individual will die. Death will be the severe consequence here. Alkalosis is just the opposite in terms of the changes to the central nervous system, peripheral nervous system. We get overexcitability rather than depression. And low levels of alkalosis, slightly outside of normal range, the individual will likely feel numbness or lightheadedness due to that overexcitability that's being experienced. And then more severe alkalosis will lead to muscle spasms, tetany, possibly convulsions, loss of consciousness for the individual, and then ultimately death as well. And I will stress here that these symptoms we expect to see when we start with acid-base imbalance. If the individual starts with an acid-base imbalance, these are the types of signs and symptoms associated with those categories of condition, acidosis, alkalosis. And I want to stress that point because when we look at the relationship between acid-base disorders and potassium, like you'll be watching in that video, we could start with acid-base disorders that lead to potassium disorders. Or we can have vice versa. We can start with potassium disorders that in the end lead to acid-base disorders. And when it's in that direction, we get the opposite symptoms associated with that. When we start with, say, hyperkalemia, the individual can experience acidosis due to that hyperkalemia. And the symptoms that will be produced, however, is overexcitability of the central nervous system, peripheral nervous system. So even though they have acidosis, because their initial problem was hyperkalemia, they have signs and symptoms that look like alkalosis. It's very, very strange and complex to think about, but it's, good types of relationships to think of for the lecture exam and how those differ when we change our starting point here for the condition. Now let's look more closely at the actual compensations that can occur with the respiratory system and the renal system. And we start here with the problem, respiratory problem, whether that's acidosis or alkalosis. If the problem is a respiratory problem, then we don't expect the respiratory system to help with the compensation. So for our purposes, for testing purposes, to make this less complex here, right? Cannot help in compensation. We're going to say that if the lungs are the problem or ventilation is the problem, then the respiratory system is compromised. It can't help in the compensation process. So what's left for compensation then would be renal compensation. The kidneys help compensate for the respiratory issues they're producing, either acidosis or alkalosis. When we have a metabolic problem, whether that be acidosis or alkalosis, we don't expect the respiratory system to be compromised in this case. It can help in the compensation, and that compensation can actually be very quick. Within a matter of a few minutes, we begin to see compensation as the individual increases the rate and depth of ventilation to remove more CO2 or decreases rate and depth of ventilation to trap more CO2. So quick compensation with respiratory system. And for metabolic problems, we're not entertaining the idea that we have kidney failure. So we're not entertaining the idea that the kidneys can't help in compensation, right? That's something that Dr. Street will review if you take her pathophysiology course, going above and beyond our compensations here to the point where we have kidney failure and now the kidneys are unable to help with that compensation. But when we determine that the patient, say on the exam, has metabolic acidosis or alkalosis, we're going to say respiratory system can compensate and so can the renal system. Right. Either way we cut it here, no matter the initial problem, the kidneys can help in that compensation is what we're gonna focus on here. And I should point out that for the renal compensation, this is more of a chronic response. We think of this as long-term changes that would occur, especially with cells in the PCT and the alpha intercalated cells, being able to change the levels of bicarbonate that is being reabsorbed or produced and hydrogen ions that are being secreted. On average, it takes about 5 to 7 days to begin to see effects of compensation for the renal system, and up to 2 weeks to see the full effects of renal compensation for acid-base imbalances. So first, let's review how the respiratory system helps with compensation. Once again, this can only happen if we have metabolic conditions. We're saying with respiratory conditions, we have compromised respiratory system, can't help with the compensation. So if an individual has metabolic acidosis, right, we know that they have too little base. Their bicarbonate levels are low. That's the problem. And for the compensation, what we want to see is a decrease in the partial pressure of CO2. We bring down carbon dioxide levels to match the low bicarbonate levels. And to bring down partial pressure of CO2, we expect the individual to remove more CO2 by changing their ventilation. Increasing rate and depth of ventilation is the active compensation that would occur. It's helping to balance the bicarbonate once again, bringing pH back to within normal range. And we see just the opposite with metabolic alkalosis. The problem here would be high bicarbonate, and the compensation would be to increase PCO2. And here we see a decrease in the rate and depth of ventilation to trap more CO2. Cells are producing CO2, right? We would generally be releasing that CO2, but decreasing rate and depth of ventilation means we're trapping more within the body as it's being produced. And here I just have that information set up as a negative feedback loop in each case, so we can see how pH is maintained, and with a few examples here for metabolic acidosis and alkalosis. So let's start with acidosis, where we have a decrease in pH. If this is a metabolic problem, some possible causes here would be excessive diarrhea. That would remove bicarbonate from the body at a very quick rate. Alcohol intake would mean excessive ingestion of acids, and that would cause an imbalance where there's many more metabolic acids within the body fluids versus the bicarbonate. And so comparatively, the bicarbonate is low. Right? And so in each case, we would say we have a decrease in bicarbonate. Right, compared to our acids. And within our body, we have various types of chemoreceptors that respond to partial pressure of CO2, hydrogen ion concentrations. Some respond to partial pressure of oxygen. We have what are called glomus cells nearby our baroreceptors that are found on the aortic arch, the carotid arteries, that sense partial pressure of oxygen, CO2, and hydrogen ion concentration. Here, the partial pressure of oxygen, not so important, but the levels of CO2, and in particular, the hydrogen ion concentration, right, is going to be reflective of the fact that we have a greater hydrogen ion concentration than bicarbonate, telling us that the pH is low. We also have chemoreceptors associated with the respiratory center of the medulla oblongata that is determining the hydrogen ion concentration and the partial pressure of CO2 within the cerebral spinal fluid. And this is the main center here for determining body fluid pH. Is the hydrogen ion concentration detected in the cerebral spinal fluid. That information is relayed to the medulla oblongata respiratory center, along with the information coming from these chemoreceptors in the periphery, the peripheral chemoreceptors like the glomus cells. The information being received is hydrogen ion concentration much higher than bicarbonate, right? Low pH. And that's going to trigger the medulla oblongata to produce an effector response, which is to increase the rate and depth of ventilation. Remove more CO2, bring CO2 down to match the low bicarbonate. And blood pH will increase back to within normal range. Then we just see the opposite here for metabolic alkalosis. We start with an increase in pH. Some common causes for this would be excessive vomiting, removing too much hydrochloric acid compared to the bases in the body like the bicarbonate. And so now the bicarbonate is comparatively higher than it would be for our acid-base comparison. And then antacid intake is pretty straightforward. That would be ingestion of bicarbonate. increasing levels there. In either case, we have higher bicarbonate compared to our acid, metabolic acids. And now that a high pH is determined by our medulla oblongata respiratory center as being an issue of lower than normal hydrogen ion concentration compared to bicarbonate. And the response here is that we see a decrease in the rate and depth of ventilation, trapping more CO2, increasing the partial pressure of CO2. Previously, we had a decrease in partial pressure of CO2. That brings our blood pH back to within normal range. Now, this information's good to note here for the acid-base compensations, imbalance compensations, but it is, relevant to the information in the respiratory lecture on external-internal gas exchange, because we do cover the mechanics or the basics for the CNS response that allows for changes in ventilation. So that relates there as well. Then we have renal compensations. Renal compensation happens at the PCT in the alpha intercalated cells. At the PCT, it is possible for us to reabsorb all filtered bicarbonate or none of the filtered bicarbonate or some of the filtered bicarbonate, depending on how much carbonic anhydrase activity we have in those PCT cells. Do we have a high activity level for carbonic anhydrase, very low level for CA, or something intermediate that will determine how much of that filtered bicarbonate can be reclaimed? And the filtered bicarbonate that is not reclaimed will be excreted in the urine. So this is the general process by which this works. We filter the bicarbonate. Once the bicarbonate is in the filtrate, it generally combines with sodium, right, as a buffer here for the base, sodium bicarbonate, as it travels into the PCT. And bicarbonate and sodium can dissociate. And when that happens, the sodium is used as a driver ion here to help secrete hydrogen ions, pump out those hydrogen ions from the PCT cells. And so here's our sodium acting as a driver. When the hydrogen ions are being secreted, they can combine with the bicarbonate that forms carbonic acid in the filtrate. That will quickly dissociate to water and CO2. CO2 can diffuse into these PCT cells, and the water will travel on. It will either be excreted or it can be reabsorbed elsewhere. The CO2, when it enters the PCT cells, will combine with water if carbonic anhydrase is active, if it's activated. The alternative to that is being inhibited. We'll talk about the conditions that cause those changes in just a bit. But if carbonic anhydrase is activated, then we combine our CO2 and water, we get carbonic acid that dissociates, and the bicarbonate can be reabsorbed again. And the hydrogen ion, right, can be pumped back out into the filtrate to combine once again with the incoming bicarbonate. And we just see this cycle occur, right, where we're reusing the hydrogen ions and we're reusing the bicarbonate. So we get no net gain or loss of carbon dioxide, bicarbonate, or hydrogen ions in this process. It's just a mechanism to allow us to reabsorb filtered bicarbonate when necessary. Now let's talk about the activity of this carbonic anhydrase. Now it turns out that no matter where we are in the body, carbonic anhydrase is most active at low pHs. Right? Lower the pH, the more active the carbonic anhydrase enzyme. Right? The higher the pH, that's going to inhibit the activity of carbonic anhydrase. We'll have less carbonic anhydrase activity. So what this means is that when an individual experiences acidosis, when they have a low body fluid pH, that's when carbonic anhydrase is going to be most active. And that's the condition under which we want to reabsorb filtered bicarbonate. We want to take it back. We don't want to lose base, right? We're going to keep the base. And so we upregulate this process of reabsorbing the filtered bicarbonate, right? So we can say with a decrease in pH, we get an increase in carbonic anhydrase activity, and we reclaim more filtered bicarbonate. Now, if an individual is having the opposite issue here, they have alkalosis, that actually inhibits carbonic anhydrase activity in these PCT cells, which is useful because we don't want to reclaim that bicarbonate, right, in this process. We want to get rid of that bicarbonate, that excess base, and help bring down the levels of base for an individual that does have alkalosis as much as possible. So when we have that increase in pH, we inhibit the carbonic anhydrase activity. We don't reclaim that filtered bicarbonate. It will move along, right? So none of this will happen. That filtered bicarbonate will move along and be excreted in the urine. And that also tells us that we'll have more bicarbonate in the urine when the individual has alkalosis, right? The urine will be basic in pH. Now let's take a look at what's happening further on with the alpha intercalated cells in the late distal convoluted tubule. These cells actually have the ability to make new bicarbonate, and we talked briefly about this process. During lecture time, we'll run through it again here. And we start with the fact that we're not looking at filtered bicarbonate being taken back in. Instead, we start with CO2 from the body tissues, right? CO2 is diffusing in and out of cells. When it diffuses into the cells, if carbonic anhydrase is active, it will combine that CO2 with water to form carbonic acid. That dissociates, and now we have bicarbonate where we didn't have bicarbonate to start. We started with CO2, right? And so now we've made new bicarbonate, and that new bicarbonate can be reabsorbed, if you will. It's brought into the body fluids in order to increase the base. Right? And we see that chloride shift. We see chloride shift in when that negative ion shifts out. The hydrogen ion here is going to be removed, and it's done through hydrogen ion pumps, proton pumps. And what's not shown here is we would have our pumps for H plus and K plus. Either way, we're secreting the hydrogen ions. Those hydrogen ions then can combine with the tubular buffers like phosphate buffers and the ammonia buffers in order to help regulate the pH of the urine somewhat. So once again, the ability to build new bicarbonate, secrete hydrogen ions while doing this, is going to depend on the body fluid pH that will determine whether carbonic anhydrase is active or not. With acidosis, we see a decrease in pH, right? Which means carbonic anhydrase is activated, and these cells would be making new bicarbonate and secreting hydrogen ions. Those hydrogen ions are going to be lost in the urine, right? This informs us as to why urine for an individual with acidosis is acidic, because we have loss in, well, secretion and then loss of hydrogen ions here along the late distal convoluted tubules. Urine is acidic rather than basic. For alkalosis, carbonic anhydrase at that high pH is inhibited. With lots of base or a high pH, we don't want to make new base, and we don't want to get rid of hydrogen ions, right? So we don't see these cells making new bicarbonate or secreting hydrogen ions in this process. So the key points here, I would say, to review for each of these is what happens in each of these scenarios here with an increase and decrease in pH. And so keep in mind the type of urine we expect to be produced during compensation matches the condition. With acidosis, right, we are reclaiming bicarbonate. That shouldn't be lost in the urine, and we're secreting hydrogen ions from the alpha intercalated cells, and that will be lost in the urine. So acidosis, we get acidic urine. And alkalosis, right, we wouldn't be reclaiming the bicarbonate at the PCT. We wouldn't be making new bicarbonate or secreting hydrogen ions at the alpha intercalated cells. So we get the loss of the filtered bicarbonate and we get basic urine. And it's useful to keep in mind that the pH of your urine actually changes over the course of a day. And this might be some information that you noticed when you were doing the urinalysis lab tutorial, that there is a normal range for pH, right? Ranges from 4 to 8, normal values around 6 for urine pH. And the reason why we get a range of values is it depends on when that urine sample was taken. If we want a better reflection of the urine pH, we would take it at multiple points during the day in order to determine the average pH there. And generally it's more acidic in the morning than later in the day, the urine. And that's because the individual while sleeping is not using glucose, right, to generate ATP, but rather beta oxidation for the most part. Lots of fat burning going on while sleeping. And this means lots of keto acids being produced, and those are going to be removed from the body in the urine, increasing the acidity of the urine or decreasing the pH, we can say.